Hello, good morning, good afternoon. Hi, Dr. Zain, how are you? I'm Dr. Raza and we're ready to see your case. I'm sorry we're just 10 minutes late, but now we go on. And we have a panel of experts from United States, United Kingdom, Turkey, and Pakistan. So I would also invite Professor Chen to come here and assist me in moderation. Can you please go ahead and tell us the history of the patient, please? Thank you.
Sure. I'm Dr. Junjie Zhang from Nanjing First Hospital. On behalf of Professor Shaoliang Chen, I really appreciate your kind invitation to participate Pakistan Live 2022. So Dr. Raza. So first, let me introduce my team. In my right hand, Dr. Ge Zhen and Dr. Li Xiaobo will assist me perform the case. And also our technician in chief, Ms. Pan Tao, will interpret the iris. So first, let Dr. Ge Zhen introduce the case information. Please, Dr. Ge Zhen. Okay. PPT, please. Okay. Can you see my slides?
No, not yet. Please switch it to slides.
Can you see the slides?
No, not yet.
Okay.
Still no slides. So you can prove. Okay, now we can see.
Okay. Okay. Ladies and gentlemen, I'm honored to here introduce the case presentation. This is the 38 years old male because the recurrent chest pain for 3 weeks admitted to our hospital. 3 weeks ago, the patient had the non-STEMI and treated with the medication in the other hospital because the recurrent chest pain and transferred to our hospital. The patient had the diabetes, hypertension, and after admission to our hospital, and laboratory test shows a cardiac mark and activity, and the eGFR is nearly normal, and BNP is normal, and the UCG shows ejection fraction 41%, and the inferior wall hypokinesis, and ECG shows inferior wall and myocardial infarction. And clinical diagnosis is unstable angina and recent inferior myocardial infarction. And we did the angiography for this patient, and this is the baseline angiography, and we can see the RCA, the distal RCA, and severe stenosis, and the lesion extended to the proximal PL. And this left coronary angiogram, we can see the distal ligament and bifurcation lesion involves the distal ligament and involves the ostium circumflex and LAD. We also can see the lesion from the proximal LAD and to the middle LAD. From the spider view, we can see the bifurcation lesion very clearly, and the lesion involved the ostium circumflex, also the OM. So next, and we did the PCR for this patient and use 2 drug-eluting stent and with the 3.5 non-compliant balloon pulse dilation. We also stratified this patient and calculate the syntax score 35 and the syntax 2 score for PCI 33. And predict the 4 years mortality 10%, and for the CABG and 34, and predict the 4 years mortality 10% also. And we calculate the NURST score and greater than 19. That means the patient is a high-risk patient. And according to the definition criteria, is the distal ligament bifurcation and meet the 1 major criteria and 4 minor criteria. That means complex bifurcation lesions. Also, next.
Thank you for introduction. So actually, from baseline angiography, it looks like a trifurcation to left man. So also we have a strong panelist. So I have some comments from panelists.
Hey, Genji, this is Tanvir. How are you? You okay?
Yeah, great to meet you, Tanvir.
So the interesting lesion, very classic of Nanjing, it is still left main bifurcation stenosis. So we already defined lesion complexity. So based on the algorithm we published, the complex lesion, and you're going to do a two-stent technique. The issue is the origin of the marginal, whether you're going to leave it alone as part of your strategy, or do some modification of the plaque, the ostium, before you do a two-stent strategy. I didn't see the amount of calcium, so obviously you're going to do some iris imaging of both branches, and if it's calcium, maybe we'll do some plaque modification. Shaoliang just told me you may have a shockwave type of balloon in China now, so it requires plaque modification to do IVL if needed before you do a two-stent strategy.
Yeah, thank you very much, Tanvir, for your comment.
Well,
So,
I
if you have any
like to see what he does, and then I'll talk about it.
Right, very nice case, very educative. It's bifurcation anatomy, complex lesion. And one thing which I see is the OM branch is at the right angle. So hopefully it doesn't look to be osteal disease. So probably one suggestion is that we'll do just 3 wires, but maybe 1 or 2 stents. Thank you.
Thank you. Angiography now, the angiography is zooming in, so clearly there is mild to moderate calcification and the proximal circumflex. So GGT, do you plan to pre-dilate circumflex and then check what's the first?
Yeah, Prof. Actually, we didn't do the predilation. According to the strategy pre-decision, we performed the iris evaluate. So let me let Dr. Anton introduce the baseline iris from the LAD, OM, and the circumflex. So please, Anton, introduce the iris.
Yes.
Okay. Hello, everyone. Can you see the iris imaging?
Yes.
Okay. Let me show the iris imaging. The first round, we check iris from the distal LAD to left main. And here, the distal LAD is normal. And here we can see the muscle bridge. And go back, we can see the septal joining LAD. And then here, it is the distal septal. And the vessel, here the vessel diameter is about 3.0 millimeter. Then go pull back. And here we can see the connection plaque. And then here we can see calcified plaque. Then go on to pull back. And here, this point is the minimum lumen area of the LAD. And here the area is just 2.7 millimeters square. But the plaque burden is more than 77%. Then go on, pull back. And here we will see the diagonal 1 join LAD. And here we can see calcified plaque. Then go on, go pull back. This is the proximal LAD. And the proximal LAD vessel diameter is more than 3.6. Then go on, pull back. Here, this is the ostium LAD. And here we can see the circumflex will join LAD. And then here, the ostium LAD area is about 5.6 millimeters square. The plaque burden is about 64%. Then go on, pull back. This is the POC, and this is the distal left main. The distal left main area is just 3.2 millimeters square, but the plaque burden is more than 86%. And then here, this is the distal left main. The calcified plaque angle is about 220. Then go pull back. This is the left main body, and the vessel diameter is about 5.0 millimeter. Then go on, go pull back. This is the ostium left main. The whole left main vessel is not normal. We make sure the netness from the distal reference to diagonal 1 is 21 millimeter.
Thank you.
The netness,
Please go
okay, the netness from the distal reference to ostium LAD is 41 millimeter. And the whole netness from the distal reference to ostium left main is about 58 millimeter. The second round, we check iris from the OM1 to left main. And the OM1, the distal vessel is normal. The vessel and the vessel diameter about 3.0 millimeter. Then go pull back, we can see eccentric plaque. Then go on, go pull back. And here we can see the calcified plaque. And this is the minimum lumen area of OM1. The area is just 2.0 millimeter square. Plaque burden is more than 77%. Then go on, go pull back, we can see the circumflex join OM. Here, this is the bifurcation of OM and the circumflex. The area is just 2.2 millimeter square, and the plaque burden is more than 71%. Then go on, pull back. This is the ostium circumflex. The ostium circumflex area is just 1.7 millimeter square. The plaque burden is more than 88%. The third one we check covers from the distal circumflex to left main, and the distal circumflex vessel is normal. The vessel diameter is about 2.8 millimeter. And go pull back, and we can see this is the bifurcation of the flex and the OM1, and the ostium circumflex is 3.0 millimeter square. Our burden is just 60%. Then go pull back, this is the proximal circumflex, and the whole length from the distal remnant to ostium circumflex is just 6 millimeter. Okay, this is the baseline.
Yeah, thank you. We have seen the IWAS findings now. Can we just request quick comments from the experts? What do they think the strategy or what?
No, I think what I suggested, one thing that Shaoliang and Nanjing taught me is to image everyone, like everybody now in a complex suicide cases. So the strategy will not change. You'll have to have some plaque modification strategy, either with a high pressure non-compliant balloon or if you have IVL, do that with distal left main. But certainly you'll have to do that before you do that. Probably end up with a crush.
We have a huge amount of classification, so we should do some kind of debugging. It's a must, and we must prepare the shock wave to plastic balloon. In fact, it's a challenging case, I think, and we have 2 bifurcations, so we must have all the materials ready before beginning this case.
Since we have limited time and we have to see the whole case, that will be more interesting. If there is any hot burning question, no. All right, we go ahead.
Oh, thank you. From I think the distal landing of first is that could be just the diagonal if you don't want to deploy to stem already. That's in the constitutional second bifurcating the velocity involved surface out to the marginal. I was confirmed 2 classified values. They look like the proximal in the same place. So what's your strategy is?
Okay, Prof. Chen and Dr. Ada, thank you very much, my distinguished panelists. The recommendation for this case. So let me introduce what we have done today. So from the first picture, actually before we do the left main, we do the right corner angiogram. You can see the previous stem was patent, and also it's definitely a dominant RC next. This is the AP code. We still show the previous 2 stem in the distal RC is a patent next. So then we switch to the left coronary. So today's PCI, we transform the right radial approach with the 7 French EDU Super 5 guiding cassette to engage the left main. This is an AP caudal view. You can see there is a severe calcification at the distal left main extension extended to proximal AID. And from this view, you cannot distinguish the ostium circumflex next. So this is IO caudal view. You also can see the first OM margin branch is larger than distal circumflex. Next. This is the RIO creative view. You can see clearly from the distal AID to the proximal and the middle AID. Actually, from angio, it's longer diffuse lesions from the left main to the middle AID. And also the very big diagonal, the ostimal diagonal is normal. Next. This is a AP clinical view. You also can see a severe calcification from the distal left main to the proximal to middle AID. Next. This is aerial clinical view. Shows clearly the distal left main eccentric plug, and also involves the ostial circumflex. Next. So this is a spider view. For distal left main, I think the traditional spider view can show the distal left main true bifurcation lesions. And considering the OM is a large branch than the distal circumflex. So from this view, we consider the circumflex to OM as a side branch for the stem deployment. Next. So this is we perform the iris evaluation sequentially from the LAD, OM, and the distal SIR. So just now, Dr. Pantel has introduced the iris baseline information. So from the iris baseline information, next, considering the distal left main calcification is significant, but the ERK is less than 270. So from this view, we think NC balloon predilation can do the good prepare for the calcified lesion. So firstly, we use a 2.5 balloon to do the predilation. Next.
Nanjing, would you have considered rota if you didn't have shockwave for the distal left main? That's my first question. Secondly, did you check EDP because the EF was low? Would you consider any support or not?
Yeah, actually, considering IP shockwave is also a very good option for this kind of calcification. Considering the EF is low, and also considering from the iris imaging, the KLC-RP is less than 217. So we think use the NC balloon predilation when we do the good preparation for these calcified lesions. So we didn't want to do the shockwave for this case. Consider it's a low FEF.
Yeah, another question is that patient LVEF is only 41%. Is IBP or impella standby?
Actually, we just puncture the left side femoral, but at this time, I think the patient is stable. We didn't insert the IBP, only standby.
Okay, good.
Okay. So according to the iris evaluate, actually from the proximal to middle LAD is diffused lesions, and also the plaque burden is more than 55. So we decided to put one stem from the middle LAD to the proximal. So according to the iris evaluation, the first stem size is 2.75 by 33 5-hop stem. Yeah, next. So this is stem position according to the angel and the iris. Next. And we deploy the 2.5 by 33 5-hop stem at term atmosphere. Next. Then this is an angiogram. Yeah, we after stem deployment. Then from the angel, I think there is stem on expansion. So next we use a 3O balloon to do the post dilation at 20 atmosphere. Next. Okay, so this is what we have done now. So according to our discussion just now, considering it's a distal left main complex bifurcation lesions, our decision is to perform iris guidance with a decay crush technique for this particular case. And also considering the OM branch is larger than distal circumflex, we consider the OM as a side branch. So that's my strategy. So if your permission, I would like to do the case with the decay crush step by step. And also the father of the decay crush technique is on the floor. So Professor Chen, you can guide us to perform this case.
Yeah, Pen is agreed with the use of decay crush. So can you show us step by step about the decay crush?
Okay, so we haven't do predilation. So I would like to predilation with a 2.5 balloon of the circumflex.
So they not the same one in cell or in obtuse, you know.
Yeah, there is a 2 wire. One is in OM when using distal third.
Okay. So is there any concern about the acute occlusion of the second glass of the pre-dilated obtuse marginal?
Yeah, there will be the possible. So that's why I put the wire to protect the distal third. And from the iris, actually the lesion at the distal third is very focused. So I think that the risk will be low, and also the angle is quite large. So I would only use the wire to protect the circumflex. So I will use a 2.5 balloon dilate the proximal third to the OM margin. Yeah. Next. Please give me a 2.75 by 23 squares.
Do you think a spider is the best view to separate the circumflex from obtuse marginal?
Yeah, I fully agree with. So please go to the spider view.
So now you have pre-dilated obtuse marginal. Is that correct?
Yeah, I have pre-dilated the obtuse marginal. Yeah. Yeah, I will do a picture at the spider view. Okay, that's one picture. Very good.
Okay.
Yeah, this is the angiogram pre-dilation.
Yeah, after pre-dilation, the blood flow is fine, so and the obtuse marginal. So next will be the first stent, obtuse marginal with short protruding to left side, right? So what's the size of the side branch stent? 2.75.
Yeah. According to the iris evaluation, so 2.75 by 23 stent were deployed from the OM to the circumflex, and the minimum protruding into the left man. At the same time, I will put a 3.5 NC balloon at this left man, which will be used to crush the circumflex stent. Okay, so 3.5 balloon.
So this is a 2.75 stent, right? You cannot see the
Yeah.
Oh,
Yeah. It's 2.75 stent in circumflex. I think there is no one chop. So I would like to go out to the
So what's the
wire.
guiding? So what's the guiding test?
It's a EBU 3.5 semi-French guiding test.
Okay. So the mammoth balloon is 3.35 millimeter.
Mammoth balloon is 3.5, Prof.
Okay. I think you can it will just
I don't have to do the position. It's a minimum protruding maybe 3 millimeter. Do you need another view to check the distal stand location? AP codal. 没有信号了。
Okay, we can hear you.
There is no signal. We lose the signal.
Yeah, can you hear us? Can you hear me?
Genji, why did you choose to go to the native circ rather than the OM? Was that because of the angle?
Yeah, now the
这是2点情况。对，就
yeah, now no connection. No audio. Jinjie, can you hear me?
Yeah, we just lost the signal. Now I can hear you clearly.
Okay, so you have deployed the stand.
Yeah. Up. And I pull out a little the stem balloon to do the post dilation and also to do the side branch optimization with a higher pressure to 12.
So this is stand balloon.
Yes.
Yeah, so recently, we have slightly modified the decay cost. We need to understand inside branch, we can use a stand balloon or another NC balloon to optimize side branch. Yeah, try to minimize the gain between stand and the climb.
So, Prof, I would like to use a 3ONC balloon to do the side branch optimization, considering the optimal circumflex is a large vessel.
Yeah, I think so. According to the hours, the proximal circumflex looks like 3.5.
Yeah.
Right? 3.5.
Yes.
So we use the 2.75 scan according to the distal diameter of 2. It could be very inside or proximal circ. So
Yeah.
this is why.
So I would like to use a 3.25 short NC balloon to do the side branch optimal optimization.
Yeah. So I think your live translation is very important to help us to understand how to do detailed course, particularly for types of patient.
Now I use a 3.25 NC balloon to do the port dilation of optimal circumflex. Please go to the spider view. So at this time, we will be very cautious. Avoid the 3.25 extending to the OM margin. Yes, please. Okay.
Yeah, I think you can put the LED balloon as distal as possible.
Oh, okay. Thank you very much for your suggestion.
Yes, process.
Safe. Yeah, thank you, Prof. More answer, please. Okay, good position. Do you have a couple of minutes?
Yeah,
That's
very good position for some place and say balloon.
Okay,
But blood flow in some place looks good.
looks good. Up.
Yeah, no more.
Then go to 16, 18, 20. This is a typical SBO.
Because there is a calcium value and it goes on substance, so during the potential standing, the maybe say in the slow flow.
After SBO, and also we check the angiogram, there is no complication for the circumflex. So that step is very important. So for DK crush, we will use a 3.5 balloon to do the balloon crush. And also balloon size according to the distal left main lumen diameter.
So called the image according to the process, you cannot see clearly how long is the protrusion of side span into the left span.
From our side, maybe 3 millimeter, 3 to 4 millimeter protruding into the left main.
Right.
Okay.
This is a main vessel balloon going to do
Yeah.
first balloon crush. Looks like
Crush.
a subflex stand. Subflex.
16. So 3.5. Up to 16. But we did not get fully brushed. You can see when I do the blue dilation, we inject the contrast. Actually, you can see there is a contrast slide into the subflex, which means 3.5 balloon is not enough, is not big enough to fully crush the distal left main stem.
So do you plan
So
to use? You plan to use another large NC balloon to crush again, or just leave it?
Yeah, I fully agree with you, Prof. I will use a short balloon, which named as a pot balloon. It's domestic balloon, very short, only 6 to 8 millimeter. But I will upsize the balloon. I will use a 4 balloon to do the post crush again. Are you agree?
So I think the period even looking at crush, because even the performance for the crush, how the size, and size, that's so now actually balloon to come to the crush on size. So the crushing has multiple steps. Each step is very This is also is for the partial.
No, I think I've learned a lot from you. I mean, so yeah, so we have got to close the gap and then a larger balloon pressing the right thing to do. Don't worry about the section you also left name, but as long as you're wired, something will be all right. Now, you know, the proximal stent optimization makes it so easy to be crossed.
After the also partial is refinement. So now it's the huge balloon. It's very short, 6 meters. And this is a particular balloon design for post down. It's very your post very fast. It's a Chinese the medicine. All this is very short. 0.3 to 0.5. So it's very difficult to get it. This is short.
这边我不太行。
So you can see some this intersection just Mr.
Yeah, that is this section. Considering the 2Y is position, on the position, so I am happy there will be safety.
How common you see these dissections while you do the main stem into the larger balloon? It's quite often, or it's very rare. Or...
Yeah, actually, if not so eccentric classification is not so often. But for this particular case, eccentric plug, there will be both. So actually, I use a third wire to divide the circumflex. So at this time, from the angle, I'm not sure it's from the proximal cell. So I will go to another view to check the wire is from the proximal cell access to the circumflex. It's very, very important for the decay crush. Two-step wire to the side branch from the proximal cell. Avoid the distal cell. Otherwise, the wire will go on under the stem structure. At this time, you can see the third wire is just overlapping with the previous jet wire in the circumflex. So from this view, from the angiogram, I think the third wire divided from the proximal cell, but it's not enough. So I will use iris check the wire position. So at this time, I will insert the wire to the LED and to the pullback and to evaluate the wire position. Professor Chen, can you hear me?
I can't hear you very clearly, but I think that because the time limit, probably
Okay.
Yeah, you only have 15 to 5 minutes.
Okay. That's fine.
So you will check hours from right to left, right?
Yeah. Okay. So Dr. Panta, please check the iris.
Yeah, I will protect the iris. Can you see the iris imaging?
Not yet. Yeah, okay. Now, okay.
Okay. The iris, this is a proximal LED. We can see the media dissection. And here we can see the circumflex virtual LED.
Yeah. It's from Proximal.
Yeah. Be sure it's passing through the proximal cell.
Okay.
So I think the wire is a very good position. So Junjie, did you remove the second wire?
Yeah, now I will remove the second wire.
Could you
The
see
previous
switch
zero wire.
to a geography?
Yeah, sure.
Good. Is this BMW wire to replace this side branch?
This wire is a Xeon wire.
Okay, see why. So then you will use 3O balloon insert and another 3.5 in RAD, right?
Yes, yes. Very sure. So LED is 2.5 to 27.
Can you play the image?
Okay. So considering the circumference there is 2.75, so I will use 2.75 and screw.
Angiogram is frozen.
Go to okay. It's on. You can see at this time I have a resistance cross 2.75 NC blue in subflex. At this time I use an angle balloon technique. Please up the 3.5 balloon to 6.
Now
you can see.
Now we cannot see angiography, which is frozen.
So
yeah, is actually, once confirm the real wire from process cell, and also if there is any resistance to pull the NC balloon into the side stand. So as Dr. Junjie just said, they are using balloon anchoring technique. In fact, LED balloon will facilitate the pass-through of the side branch balloon.
So before the first simple inflation, we sequentially post-dilate the optimal subflex with a high pressure.
Okay, now we can see angiography very clearly. I think the NC balloon has entered into the subflex. What's it diameter?
Yeah, with
It's
3.75.
okay. So
with the angle balloon technique. Yeah, then we do the first kissing.
okay.
Yeah,
How high? 16 or 18? 16,
18.
18.
Oh, 这个对我
High enough. So, yeah, why not a location? Location. Yeah. Actually, for NC balloon, there is very, very slight increase in diameter between 14 to 24.
After first kissing inflation with the 3.5 and the 2.75,
Yeah,
now we
I think so.
switch to 3.5
Yeah,
standing.
Yeah, another very important point is that during kissing inflation, so the older plants of two balloon vessel should be ensured that good because we try to reduce, recreate metal environment to avoid the extension, elongation of the environment. So you have successfully performed the first kissing, right? So next step will be very easy for you. So what's the next? What's the length of the next step?
3.5 by 29, 5 Hawk step according to the iris evaluation. Let's go to the IO clinic.
Okay, so the first scan in AD was a 5 Hawk, right? Is it still 5
Yeah.
Hawk?
Still, I use a 5 Hawk.
Okay, can you tell us what are the advantages of 5 Hawk step for just left left lesion?
So first, the high Hawk, actually, there is a very important study compared with Lancet and the non-inferior to this Lancet step. And the first, I think the most important, just as you mentioned, for distal level bifurcation lesions, 5 Hawk, the radial force is quite good. And also the stent open cell is very suitable for sidebar access. And the most important thing is for 5 Hawk, the post-dilation ability is quite good. Like 3.5 stent can very safely achieve to post-dilation up to 5 millimeters. So on this view, I think for this particular case, 3.5 stent crossover circumflex, and for the Proximal, for the left man, we can safely use 4.5 to 5 below to do the post-dilation.
Okay. So I highly suggest to move to aerocranial to identify the location of
Okay.
left main. Do you plan to
Okay.
cover the whole left main?
Yeah, surely, because from the iris imaging, the left man is diffused lesions, aerial greening. So I would like to fully cover the optimal left man from. So what's
Yeah, for any stent covering osteo left main. So to avoid the longitudinal compromise is very important. So you are using EBO35 guiding catheter, it will be Prof. Because we need to yeah, they did not use actually from rivals. I will prefer to use the cutting to prepare those inheritance flex. Because I was informed the calcified nodule.
Yeah.
Yeah, which is the typical sign of SASS level lesion.
But he didn't opt for cutting balloons over here. And what is your have you ever used a cutting balloon into the left main also?
no,
Yeah.
after encephalon post-dilation, and the iris show.
They did not use.
Yeah.
But Junjie is very strong. Junjie is very strong in treating complex issues.
Dr. Zain, one question for, especially for fellows, and do you cover the left main till ostium, or we can stop in between, or it depend on the length of the main stem or the lesion? Can you give some comments to an expert, your experience?
For the left man, if the left man is longer than 55 millimeter, according to the intracorneal imaging study, actually is always diffuse lesions from this case from the inflammation. For this case, I will fully cover the optimal left man, avoid the joint orthotics, and also just as Prof mentioned, at this time I will be very cautious to avoid the guiding catheter. Cause the stent distortion. Yes, please.
I feel this is a good
So-
prediction.
Are you happy?
Whenever we are doing this left main, up to the left main, there's always this big debate. Should you hang 1 millimeter out or should you not hang? So that is the thing, because getting it right at the left main is always an osteal trick. So what is your take on it?
Yeah, right. I think a maximum protrusion limited to 1 millimeter is a requirement. And also, for some junior populations, it will be very tough. But to achieve the maximum 1 millimeter protrusion, multiple injection, particularly aero session, so basically.
The left means always at an angle, so you have some protrusion coming.
Yeah.
And if put the marker wire there, you notice, you
Yeah.
see where the ostium is.
You hang a wire over there or
Yeah.
something like
You
that.
can put a marker wire.
You put a mark wire over there.
You can-
How much is the inflation pressure?
I inflate the stent at 12 atmosphere. Then I pull back a little and do the post dilation with the blue to 18 atmosphere. Then I will still use 4O and C balloon to do the post dilation before I rewire the circumflex.
So this that's why it's still in position.
Yeah, I just pull the wire in the aorta. Yeah. To avoid the guiding catheter injuries osteomolapse stent.
So I think the spot view will be much better.
Yeah, go to spot view. Thank you, Prof. Thank you for your time. So I put the circumflex wire to the aorta, avoiding the guiding injuries.
But this is very important. This is very why. Just prepare on time. Yeah, about why. So let's see the low not
Yeah. Yes. Up.
But left larger than 4 over, it is supposed to 5.5.
Right, the best target is inside. The best line to have target is 2.5. So they use a slow down by high pressure. I think the extent diameter could be achieved by
20. Up again.
It's a good position to participate.
20.
And watch the side of
Yeah. I think at this time we are inflate balloon and I do the contrast injection. There is no contrast leaking in the distal areas, which means the stent is fully, I think it's a issue.
Okay, so we have 7 minutes more, and then we will leave it to. If it is
Okay.
We have 7 minutes.
Thank you. Okay, I will do the. Thank you very much. I will do the final step. I will do the final rewire. And before we rewire, we do the angiogram.
Because ideally you should have 10 minutes because we started late by 10 minutes, but just to be comfortable, what you best you could show to us.
At this time, we are secondary wire are still from the proximal cell. So I will still use angio and the iris guidance. I think the wire took a little damage. Maybe I will change the new wire. See how wire is. Sorry. Excuse me, a new wire. See. And the patient is stable. Let me take a picture. At this time, I think it's from the proximal cell. Go to the AP column.
By the time Dr. Zaid is trying to recross, can you find also opinion to how many of you would do the OM also, because it's a disease in the osteum OM, osteal OM. Is there, would anyone leave OM and just do those things? Yes, yes, just a second.
The old saying, best is the enemy of good. So,
you'll go for
yeah, probably, but see, my only one question is that his procedure has gone out very well. He first did the RCA, and then he proceeded. If he had not done the RCA, would he have been comfortable? Because many times in the world of economics, you'll say that this gentleman has triple vessel disease, and they are bad calcified lesions. So, if from a bypass graft surgery point of view, he will get these 4 grafts. But from an angioplasty point of view, then you'd say, yes, his obtuse marginal must be done also. Because from a surgical point of view, it was a target. So it has to be done. So, but should it be done in the same sitting or not? Now that becomes a question, because after such a prolonged procedure, what kind of allegations of troponins has already happened, that we don't know.
Dr. Zhang, we have 2 presentations ready from United States. So is it okay if we leave? We really learned a lot from this wonderful accident case, and very nicely done. So is it okay if we just leave in now, and congratulations for doing everything so far so good. All right. So we now disconnect and go to the other hall. We have one lunch ready for you, and another section in Shish Mahal 2 hall, where Dr. Usama Mahan is going to start our presentation. Thank you, Dr. Zaid, and your team. Thank you very much.
Thank you.